Hi, and welcome to our presentation that we have for you. It's the UVU Ethics Awareness Week 2021. My name is Jenny Olson, and I will be the moderator for this session. This session is entitled COVID, Civics, and Civility when Disinformation Spreads Faster Than a Virus. This session is presented by the College of Health and Public Service at Utah Valley University. The session was coordinated by Dr. Sarah Hall in the Department of Public Health. Our panelists today are Dr. Francine Jensen, Dr. Allison Ensign, Dr. Sarah Hall, and Dr. Heather TSA. I'm glad to welcome them. Francine Jensen is an associate professor of nursing at UVU. She holds a PhD in nursing research from the University of Utah, a master's degree from George Mason University, and a bachelor's degree in zoology. Dr. Jensen's nursing experience is as an emergency and trauma care, as well as medical surgical nursing. She is the program coordinator in the Department of Nursing and has managed the COVID response for over 300 students and faculty during the pandemic. Her research and publications focus on increasing end-of-life care and disadvantaged populations, improving the intercultural competence of nursing students. Dr. Allison Ensign is an assistant professor of nursing at Utah Valley University and a family nurse practitioner at Brigham Young University Student Health Center. She holds a Doctor of Nursing Practice degree from Frontier Nursing University and a bachelor's degree in broadcast journalism from Brigham Young University. Allison's experience in nursing includes cardiac, primary care, labor, and delivery. She has been a family nurse practitioner since 2017. She has been actively involved in educating, diagnosing, and managing care for outpatient COVID patients throughout the duration of this pandemic. Recent scholarly publications include research on nursing faculty practice, student final pass-offs, gamification in the classroom, and obesity management in primary care. Dr. Sarah Hall is an associate professor of public health at Utah Valley University. She holds a PhD in global health from Arizona State University and a Master of Public Administration with an international nonprofit management emphasis, BA in English and minors in African Studies and Dance from Brigham Young University. Prior to her career at UVU, she worked as an executive director, marketing director, and in consulting positions for nonprofit organizations in Ghana, Tanzania, Kenya, Mexico, and Indonesia, Thailand, and the United States. Dr. Hall serves on the Ethics Advisory Board at UVU. Her research history includes earthquake and tsunami preparedness in Indonesia, flu vaccination messaging in the United States, albinism in Tasmania, and barriers to medical care for the deaf populations. Dr. Heather TSA is an assistant professor of healthcare administration at Utah Valley University. Dr. TSA received her undergraduate and master's degree in public health from Brigham Young University and her PhD in public health from the University of Utah. She spent 12 years of her career within the Department of Surgery at the University of Utah, conducting health service research and clinical trials as the Associate Director of Research and Science. She specialized in healthcare administration, leading the Division of Transplantation and Hepatobiliary Surgery for 7 years. Dr. TSA's research focus is in pain management and the opioid epidemic and healthcare access. She has published numerous scientific articles and related to physician prescribing practices and the effects of patient with opioid use disorder. Thank you very much to all of you, and we are going to start the conversation.
Welcome to our presentation. We'd like to thank Jenny Olson for being our moderator for our session today. We're an interdisciplinary group with expertise in community and public health and patient treatment and management. Our presentation today will cover the ethical issues that are impacting the global world, healthcare providers, and how we as individuals can navigate the political, informational, and social climates as we continue to experience the COVID-19 pandemic. My name is Francine Jensen. I'll be discussing the global impacts on healthcare workers professionally and personally. I apologize, I'm looking for the advance button. All right, I found it. We live in a world that has become increasingly globalized over the last 50 years. Experts point to changes such as freedom of trade that enables interactions across borders and oceans, increased labor availability in other countries, which allows businesses to use overseas workers, for instance, in India or China, improved communications and technology, with platforms such as WhatsApp that allow people to talk with others all over the world. Connecting globally has never been cheaper or easier. And improvements in transporting goods and people. For instance, the World Trade Organization, I apologize, I gotta go back a screen. Thank you. The World Trade Organization reported 1.4 billion international tourist arrivals in 2018, meaning international travel was at an all-time high, as you can see in this graphic. Think about this impact on the global economy, global tourism industry, and global relations in general. We are increasingly interconnected financially, socially, and physically with people half a world away like never before. So when you overlay this mobility and interconnectedness on the COVID-19 pandemic, it's no wonder that the last 18 months have been so unique in history. These connections have impacted the health of our entire world. And who's watching out for the health of our worldwide citizens? At the global level, the World Health Organization keeps a finger on the pulse, so to speak, of global health. They promote worldwide health, keep the world safer in general, and serve the vulnerable. One of their stated goals is to protect 1 billion more people from health emergencies. They're an agency under the United Nations with 194 nation member states. They're funded by a combination of members' fees based on their wealth and populations, and the United States is one of their largest contributors. President Trump threatened in May and June of 2020 to pull out of the WHO, stating discontent with the WHO's stance on China during the pandemic. This was reversed by President Biden in January of 2021, and the US is still part of the WHO today. At the national level, several organizations are involved in the health of US citizens, such as the Centers for Disease Control, the National Institute for Allergy and Infectious Disease, and Health and Human Services. These are all funded by our taxpayer dollars. At the local level, each state has a Department of Health that works closely with health county departments, divided into even smaller units for caring for the local health of members within their communities. As an emergency room nurse, I've seen how this works. On a daily basis, hospitals and doctors report to local health departments. For instance, if they suspect a contagious exposure of some kind in their emergency room. In turn, these state organizations report this information to national organizations, and if needed, international organizations, to safeguard the health of the world. This information could also be passed the opposite direction, from the WHO to the CDC and back to the local health entities. This structure has worked for a long time to safeguard not only our communities, but our nation until COVID-19, but more on that in a moment. Here's a sample of some infectious diseases, viruses that have shaken the world or parts of the world, and the timeframes that they were most highly transmissible, and the areas that were in crisis mode. With a cooperative effort, these threats were identified, monitored, and risks shared across the world. Illness and spread were mitigated because this information was passed, luckily for all of us. Unfortunately, in the early days of COVID, with the Trump administration leading the United States, the passing of health information took on a politicized tone. In my opinion, it did not help that the COVID-19 pandemic started during an election year. What information formerly would have been passed from the CDC and disseminated back to US citizens took a decided turn. There was a breakdown in communicating risks, benefits, and timelines as President Trump's COVID task force took CDC information and filtered it before putting it out to our citizens. COVID has impacted all of us, but I want to talk specifically about the impacts on healthcare workers. They've been on the front lines for months now, interacting with the sickest people in the United States. They've dealt with understaffing situations. Initially, they had inadequate personal protective equipment. Not only were they at risk of catching COVID, but they put the people that they lived with at risk by nature of the disease, because early on we had little information about how it would spread. They faced ethical quandaries when faced with rationing care to multiple critical patients at any given time. Resource allocation was affected, having enough medication and the right equipment that worked. Do you recall the conversations about the strategic national stockpile that was intended to have a stash of medications and ventilators for national emergencies? But both were outdated and undersupplied, so critical shortages were everywhere. The government was not prepared to shore up this drastic national occurrence with COVID-19. In addition, the nature of nurses' relationships with patients changed drastically. No significant others were allowed in hospitals, so patient psychosocial support was limited. Many patients died alone. This situation made one nurse state, "When we look back at the pandemic, having patients die alone may be the biggest mistake of the pandemic, because it directly goes against best practices and ethical care for dying patients." This slide captures quotes from patients who were not vaccinated, who ended up hospitalized or had a loved one who was affected or died. One hospitalized patient said, "I would like for the politicians to bow out and let the right people talk. This is a health issue, not a political thing." Another patient said, "The vaccine may not stop you from getting COVID. Don't be stupid. It's just going to prevent you from fighting minute by minute to be with your loved ones." Statements like these share what we call vaccine regret, people who wish they'd gotten vaccinated when faced with a major health consequence and it became life-threatening. This is a real phenomenon where people are affected by disinformation or lack of information that may drive their healthcare choices until their options become limited by exposure or underlying disease. For some, it comes too little, too late. There are disparities among those most affected by COVID. Older adults are affected more often, and individuals with 1 to 3 comorbidities and who are over 65 are 2.5 to 5 times more likely to be hospitalized. In addition, individuals who are affected by social determinants of health, such as access to care and education and income, are disproportionately affected. And we are still trying to understand the long-term effects of COVID on individuals over time. The end of August 2021, the WHO made the following statement. The World Health Organization has called on countries to delay giving out booster shots of the COVID-19 vaccine until nations with low vaccination rates can inoculate more of their populations. We are privileged to live in a country, yet many in other countries find themselves with limited or no access to life-saving vaccines. This particular infographic demonstrates the disparity of vaccine status among countries. The end of June 2021, 80% of vaccines had been given in high and upper middle income nations. For instance, 65% of individuals in the United Kingdom had been vaccinated, while only 7% of people in the Philippines had. And another disparity points to the US vaccinating its teens, while frontline workers in Nigeria are still awaiting vaccinations. The WHO estimated that by diverting doses to other nations, if we waited 2 months for booster shots, 10% of the world could potentially be vaccinated. There's no question that this has been a challenging time for nurses, healthcare providers, and all of us. And it makes us rethink what we're doing, why we're doing it, and how we can do it better in the future. I leave these thoughts with you that we're interconnected globally as never before. And COVID-19 has demonstrated what impacts one economy and even on our daily health have the potential to impact all of us. And we can ask ourselves, how can we be the best global citizens, US citizens, and local citizens? Because it will take all of us now and in the future. My colleague, Dr. Allison Ensign, will address you next.
Thank you so much, Dr. Jensen. I appreciate that. I'm happy to be here to be addressing this COVID infodemic, the the public health ramifications, and some ethical quandaries that have emerged for both healthcare providers and for our community. And at a year and a half into the pandemic now, I know we can all relate to this couple. The lady is saying, my desire to be well informed is currently at odds with my desire to remain sane. We're exhausted with the disease, the mandates, the bombarding of constant information that we are hearing. And this leads to a new term that I think you might also understand and be able to relate to, and that is infodemic. It's defined by Oxford Languages as an excessive amount of information about a problem that is typically unreliable, spreads rapidly, and makes a solution more difficult to achieve. So let's break that down into segments and examine how accurately the COVID-19 pandemic fits this definition. So excessive information about a problem, typically unreliable, spreading rapidly, and a solution is difficult to achieve. I think we can agree that it really fits perfectly to what we're experiencing now. So what are some of the ramifications of that, and how do we manage it for protecting mental and physical health of our community? First, excessive information about a problem. Where does the excessive information come from? The answer is everywhere. News, our jobs, our children's schools, our schools if we're a student. Social media is flooded with COVID articles and memes. Anytime we talk to friends and family, we know that there's a large percentage of them who have been afflicted or are worried that they will be afflicted. There are political discussions, visits with our providers, really just about anywhere you can think of. The cashier at the store, our hairdressers, our dinner conversations have all been revolving around COVID-19. But what constitutes reliable? And as you think about those sources of COVID news and discussions, which, if any, do you trust as reliable? And has your opinion changed over the last year and a half? How many folks really know how to determine what is reliable? There is a quote usually attributed to Mark Twain that says, "A lie can travel halfway around the world while the truth is putting on its shoes." And the interesting thing about that is we don't even have proof that Mark Twain ever said that. So ironically, sort of proving the point. In the past, far-reaching media formats were really limited to a few major newspapers and networks who basically gathered their information and their news directly from their own employees. But news gathering has changed dramatically with the new formats and the new speed of information dissemination. I was a news anchor and reporter 30 years ago, and in that time frame, so much has changed in the profession of journalism. If I was to go back now, I think it would feel like a whole new employment, a new job for me. And during this time, because of those changes, a new phenomenon has emerged, and it's called circular reporting. It happens when one news source publishes misinformation, the next news source reprints it, then the first publication cites the second publication as their source, and it completes this circle, and nobody is asking anymore where it all started. What was the original source? And one example of this was the 1998 publication of a pseudoscientific paper that stated vaccines caused autism. You may have heard of it. The result was a huge anti-vaccination movement. Even though the first paper had been repeatedly discredited, there was this spreading of information from one publication to another, and the unfortunate result was that a big upswing of children contracting previously eradicated diseases, and in some cases, those diseases were fatal. And another example of that is these user-generated websites like Wiki, where an unverified fact on one of these pages can make its way into a published article. And then if our authors aren't careful, that published article becomes a source for another journal article. And the legitimate sources are now printing information from articles that they thought were scientific, and it becomes harder and harder to debunk the false information. So the reality is that most citizens do not really understand the difference between these feelings or what looks to be reliable and what is actually scientific criteria and a scientific source. So we need to be very cautious about that, where some things can appear to be reliable. Some news agencies and articles do an excellent job of appearing to be scientific when they really have no background in that. So another criteria here of our infodemic definition was spreads rapidly, and how quickly we get our news now compared to 30 years ago or even 5 years ago. You know, there was a day when we had to wait for the 11 o'clock news or our morning paper to hear the news. And now a viral article or meme can take hours or even minutes. The speed is exponential and magnified as thousands of friends are sharing news at the same time, and that web of information continues to grow. And the fear really is that the desire for quick answers is overpowering the desire for truth and validity. So with all of these cooks now in the kitchen, it's inevitable that conflict will arise. Not like the old days when there was one community doctor who made house calls with the black bag and their answer was the end-all answer. Now we have questions of trust and opinions and confusing voices that are all yelling to be heard. And the question does arise, whose opinion matters and whose rights even start to matter. And we have some people, you may have heard this statement similar to this, that they say, I have a constitutional right to decide for myself if I should get vaccinated, or a right to decide if I am going to wear a mask. And at the same time, others are saying, well, I have a constitutional right to go to school or work without the threat of contracting a deadly disease. So in that sense, it becomes very difficult and to decide whose rights matter more when both entities are saying they have the right. It's really no different than these long-lasting disputes over right to life or right to carry a gun, right to dress the way that we choose to. Who should decide on limiting freedoms? And these are some of the ethical dilemmas that we find ourselves in now with the COVID situation, where we're looking at personal liberties versus the interest of the community. This diagram illustrates in a quite basic way that dilemma and even the hope that public health and personal decision-making will intersect. And then in the middle there, we will achieve community survival, strength, and success. But the problem is what happens when they don't intersect and personal decision-making does not support or strengthen public health. So then, of course, the community survival, strength, and success becomes compromised. So the challenges that happen can pretty much here, as you see on your screen, be compartmentalized into access to care and mandatory measures. So the access to care would be our testings, our vaccines, and treatments. And as Dr. Jensen mentioned, there are some social disparities that exist between different countries of origin and exposure considerations like healthcare workers. There's differences between insured and uninsured folks. And then you look at the mandatory masking, the testings, the vaccine. This topic is really on fire right now. The questions that are being asked about personal liberty versus community good. And as a healthcare worker myself, I can share a little bit of my perspective with this. I have certainly noticed while managing patient care that there is a shifting of attitudes. There is a bit of a loss of respect of education and experience, where I think, especially with COVID, I've had few patients come in at this point and ask me what my recommendation is on that. You know, asking me, should I get the vaccine or do I need to wear a mask? I think that most patients now have made up their mind on that, and they're quite comfortable actually telling me their opinion, even if it contrasts with mine. I've heard the take that, you know, nothing that I say would change their mind at this point. And I think that that is sad, but I also think it's probably true that there is a certain investment that many of the patients I see have in the opinions that they've already formed, and just really not willing to change or to think differently at this point. And this brings to mind this sort of idea that I'm trying to convey here, where in the past we had physicians, and you see here some sort of community medicine man, I'm not sure who that is, but they are considered to be a trusted source. And we have a poor patient here who is coming for treatment for a headache. And so those of you who may have suffered migraines might understand this sort of urgency or deep desire to try anything that might cure it. But you also might look at this with some degree of horror and think, how on earth, did they think that this might help? But you compare that to medical providers of today who have this obligation to keep their license. They must practice with evidence-based. So in order to continue practicing, they need to have proof of reliability and validity, and they are at risk for losing their license if they don't practice that way. So that's sort of just my take on the shifting of attitudes and some of the hostile environments that are created because of the emotional responses that are linked with this. There's a destruction a bit of the healthcare provider-patient relationships. Friends and family relationships are being compromised, or in some destruction there as well. But I do feel there is a responsibility and an obligation for the dissemination of evidence-based information. The medical field practices under an oath to do no harm. So healthcare workers really inherently have this fiduciary responsibility to prevent harm to their patients when precautions and evidence are available to prevent the transmission of disease. So here you see a common ethical diagram that shows two theories that are sometimes at odds with one another: the theory of deontology versus utilitarianism. Deontology holds that goodness, or being right, is determined by the action. So ethical behavior will have goodwill behind it. And then utilitarianism is consequence-based, and it holds that goodness is determined by the outcome. The right or ethical behavior will result in the greatest amount of good for the most amount of people. So how do these theories apply to COVID then? For me, it raises the question, should I be focusing on deontology, or do my choices have goodwill behind them? I think about the personal decisions to wear masks or getting the vaccine, or for advocating for others to either get it or not. And so, I sort of have to ask myself that medical promise, am I keeping that commitment to do no harm? And at the same time, do my personal choices and the way I treat my patients bring the greatest benefit to the largest number of people? So these are questions that healthcare workers must ask, and I think really any citizen of the planet Earth should be asking themselves at this point. Can they answer that those do have goodwill in those actions that they're doing, and are they bringing about the greatest amount of good to the most amount of people? Well, this is not the first time in history that a health pandemic has raised such ethical questions as these, and I'm sure it's not going to be the last. This is a drawing from 1875. These folks are out and about, and the title here is Happy Hampstead, a Suburban Plague Ground. So the family is out in the plague ground, and the gentleman says, "Ha, my dear, this is what I call pleasant." But there you see this threat of fever and smallpox looming over them. And over 150 years later, we can easily, I think, substitute COVID over those demons' heads, and we could all certainly relate to the feeling and the predicament here. So it is no easy task managing this threat of COVID, the COVID infodemic, and the misinformation that is circling around us constantly. I think as we continue to do our best to work out those best answers, we will find success in the end for ourselves and for our communities. So this concludes my portion of the presentation, and Dr. Sarah Hall will take it from here.
Hi, I'm Dr. Hall, and I will be speaking primarily on social media and COVID-19, including how disinformation led to politicizing the virus and a decrease in institutional trust. So our perceptions can be influenced both by the type of information that we receive and also our interpretation of that information. So what we see online is often dictated by an algorithm's best guess of what we would like to see based on things like our location or our search history or recent click behavior. These filter bubbles result in skewed information where we are less likely to be exposed to opinions that challenge our existing perceptions and more likely to be intellectually isolated in our own echo chambers, while we enjoy the illusion that the majority of people are in agreement with us, whether or not that is truly the case. And then we have confirmation bias, which instead of resulting in skewed information, results more in skewed perceptions. So the way that we seek, interpret, and recall information is impacted by our existing beliefs. When we come across evidence that is outside of our existing beliefs, we might ignore it or misremember it or look for information that disproves it. When it comes to social media discussions about COVID, you see a lot of different logical fallacies circulating around social media. So I just want to give a few examples of that. First, we have the sunk cost fallacy. So for example, there are people who are on their deathbeds dying of COVID who refuse to believe that it is COVID that they are sick with because they previously invested so much energy into the idea that COVID is not a serious illness. Next, we have appeal to authority. So in many instances, authority can lend itself to credibility, but it can become a problem when someone overstates their credentials or their experiences within a given area. So for example, when ICUs were filled to capacity, I saw someone on social media post that as a doctor, he could personally vouch that there were plenty of beds open. But I knew this person to be an optometrist and not an ICU doctor. So I was getting very different information from the doctors who were working directly with COVID patients in the ICUs. Another one is appeal to ignorance. This is a common one. We often see the phrase, "we don't know the long-term side effects of the COVID-19 vaccine" online. This is an appeal to ignorance because it focuses on what we don't know about the vaccine instead of focusing on what we do know from the clinical trials and from the millions of people who have been vaccinated already. And then we have the false dichotomy, the idea that we have to choose between one thing and another. So it's either health and lives, or it's the economy and livelihood. Or vaccines either save all lives and prevent all infections, or they don't save any lives or prevent any infections. So when someone posts an article about a vaccinated man who died to suggest that vaccines are not effective, yet ignores the big picture data that shows that vaccines reduce hospitalizations and deaths, then they are using this logical fallacy. The last is the slippery slope fallacy. One application to COVID is that if we allow the government to issue mask mandates, they're going to try to control us more and more until we lose all of our autonomy and we all end up living in the Handmaid's Tale before we know it. We also have the ad hominem logical fallacy. So there's a few different types of ad hominem. One is abusive. So ad hominems in general attack a person or an institution instead of critiquing the ideas that are promoted by the person or the institution. So the abusive ad hominem would be, for example, name calling. So calling people who choose to wear a mask or get vaccinated sheeple would be one example. Another example would be calling a person who isn't wearing a mask selfish without maybe knowing, does that person have COPD? Does that kid have a sensory disorder or something like that? We also have guilt by association. So for example, pointing out that this particular leader who is advocating for mask wearing worked under a president from the political party other than the one that we are in. Therefore, this person cannot be trusted and they must be bad because they belong to this other political party. So instead of it critiquing what they're saying, it's associating with them with the other political party. Therefore, nothing that they say can be worthwhile. And then the last one is appeal to hypocrisy. So for example, my mom went skydiving when she was younger. And if I came to her and said, "Hey, I want to go skydiving," and she said, "Hey, that's not safe," and I said, "Well, you went skydiving when you were younger," this would be an appeal to hypocrisy. It doesn't address the danger of the skydiving. It only addresses that person did it too. So if we look at this picture on this slide, this is an example from the pandemic. This picture of Dr. to his wife and his close friend. And as you can see, he has his mask down around his chin. So people were criticizing the legitimacy of masks based on the idea that Fauci was caught not wearing one. This is an appeal to hypocrisy because whether or not Fauci was wearing a mask in that moment is irrelevant to the truth about the efficacy of masks. And as a side note, he is outdoors in a nearly empty stadium, and he said that he tested negative for COVID earlier that day. And he said that he pulled down his mask for a moment to take a sip of water. You can actually see the water bottle in the photo. So one day I was just a little bit frustrated at the fatigue of trying to stay on top of all this misinformation and try to get the correct information out there. And so I decided to create a COVID social media bingo game with some of the misinformation that I had seen online at the time. So here are a few of the things that were in the bingo game. I'm not going to go through all of them, but the board items ranged from Bill Gates made the virus to the flu kills more people, which may have been true early on in the pandemic when relatively few people had been infected, but it kind of ignored how fast it was spreading and how serious it was. Another one, only 6% actually died from COVID. I'm going to go more in depth on that one. To even a new world order, presumably from businesses asking people not to use cash to pay, would then result in cryptocurrency, would then result in a new world order type of a thing. And I definitely had a blackout on this board when I scrolled through social media. So I want to go more in depth and just use one of the pieces of disinformation as an example of how information can be taken out of context and presented to misinform people. And so the one that I want to talk about is the one that was widespread during August of 2020. And there was a phrase, only 6%, that was trending on Twitter at the time. There were various iterations of the social media post, but one common one was circulating, and so I'll go ahead and quote that one. It said, "This week, the CDC quietly updated the COVID number to admit that only 6% of all the 153,504 deaths recorded actually died from COVID. That's 9,210 deaths. Your chances of dying from COVID are only 0.00003%. And included in the social media post, there was a small screenshot of the CDC's website with the number 6% circled in red. So this post had really specific numbers. It had an actual screenshot from the CDC. So a lot of people took this to be legitimate information and shared it. The post also encouraged distrust of the CDC because it used phrases like quietly updated, like the CDC was doing something sneaky, and also used the word admit to suggest the CDC was admitting some kind of wrongdoing. And this was actually retweeted by the President of the United States at the time. It was also retweeted by a lot of influential local people with huge social media followings. So the issue with this is that if you actually navigate to the CDC's website that the post was referring to and read the whole phrase that had the number 6% in it, what it said, and this was a direct quote, was for 6% of the deaths, COVID-19 was the only cause mentioned. So there's a difference between these two and a false misinterpretation. So I'm going to talk a little bit more about why this was an erroneous interpretation. So first off, the information came from death certificates. And we need to understand how death certificates work to understand how to interpret this statistic. So I have a screenshot here of a death certificate. You can see part 1 and you can see part 2. So in part 1, under A, you list the immediate cause of death. And then B, C, all the way down, you list the sequence of events down to the underlying cause of death, which is the condition that caused that whole sequence of events, set that whole series of events in motion that eventually led to the death. And then part 2 here is where you list other significant conditions, for example, underlying conditions like diabetes or asthma. So if you look under the example, this is an example patient in the bottom right picture here. So part 1 of the death certificate shows that the patient's immediate cause of death was respiratory arrest. This was due to or as a consequence of pneumonia. Pneumonia was due to or as a consequence of COVID-19. So the patient contracted COVID-19, which led to pneumonia, which led to respiratory arrest. which resulted in the patient's death. So COVID-19 in this patient situation is the underlying cause of death. The patient would not have gotten pneumonia or had respiratory arrest had they not gotten COVID-19. And there's no underlying conditions listed in part 2 for this patient. So while there are three additional causes of death listed on this death certificate, they died from COVID-19. That's the underlying cause of death. According to the social media statistic, because COVID wasn't the only thing listed on the death certificate, they must have died from something else. Therefore, they must not be counted in the COVID deaths. So again, the social media's misinterpretation was that only 6% of the CDC's death count actually died from COVID-19. Therefore, they extrapolate that the rest, 94%, died from something else. You may have heard the phrase "with not from COVID" that was circulating a lot last year. So that was the interpretation, with the implications that COVID is overblown, it's not that serious, the CDC cannot be trusted. But if you look at the actual interpretation on the death certificates, 92% of the death certificates listed COVID-19 as the underlying cause of death, which is the initial condition that led to the death. And the 6% number was really just describing the data set. 6% of the death certificates listed COVID-19 as the only cause of death. Likely interpretations of this is that maybe the medical professional didn't know which organ system failed first, or maybe they just were not thorough when they were filling out the death certificate, so they didn't list a more specific immediate cause of death. So when this piece of social media disinformation was floating around, I immediately went to the CDC's website and I downloaded the data set that was associated with the statistics, which was actually available to the general public at this time. So a lot of people online were claiming that those who were listed as having died from COVID were already on death's door and they would have died anyway, regardless of whether or not they had gotten COVID. But the data set actually said otherwise. Some of the most common, if not the most common, additional causes of death that were listed in the data set were conditions that were likely caused by COVID. So for example, 42% of the death certificates listed pneumonia as one of the additional causes of death. 34% of the death certificates listed respiratory failure as one of the additional causes of death. And there were other contributing underlying health conditions from part 2 as well, but they were less common. So for example, hypertension, 22% of the sample, which is not surprising to me because nearly half of US adults have hypertension in general. Diabetes, 16%, chronic lower respiratory disease, 8%. So let's go back to the original social media post. So it claimed the 6%, but then it went ahead and also said, that's only 9,210 deaths. Your chances of dying from COVID are only 0.00003%. So let's talk about how these were calculated. So the way that they got the around 9,000 deaths was they took 6% of 153,000 and they got 9,210 deaths. So we already know that's wrong because we know that the 6% was a faulty number to begin with. We know that the true number was 153,504. So that one's taken care of. The next one, they then took that number of deaths to calculate a chances of dying from COVID statistic. So we already know that the death number, about 9,000 deaths, was way too small. But now they're dividing it by an incorrect number as well. They actually divided it by the entire population of the United States and then presented it as a chances of dying. So they were presenting it more like a case fatality rate and calculating it more like a mortality rate. Obviously, if somebody has never had COVID-19, they have a 0% chance of having died from COVID-19. And this also ignores that it's still spreading in the community and more people are going to die from COVID-19. So the denominator was way too big. It should have only been people who had been infected with COVID at that time, not the entire population of the United States. So then they went ahead and divided it and they got 0.00003. And then what they did is they slapped a percentage on the end of it and they called it 0.00003%, when really you need to multiply that by 100 in order to express it as a percentage. So even if the numerator and denominator had been correct, which they were not, the percentage result was still 100 times too low. And if we look at the actual case fatality rate in the United States, according to Johns Hopkins, the actual case fatality rate, the observed case fatality rate is 1.6%. And the current mortality rate in the United States is more than 1 in 500. That includes people who have and haven't been infected with COVID, 1 out of 500 Americans. And then the total deaths in the United States is now, I believe it is over 692,000 now, up from just a few days ago when we finalized this presentation. And unfortunately, one of these additional deaths that happened within the past 2 days was my friend from college's dad. Her and her mom and her dad were all hospitalized with COVID. She's younger than me. They were all in the hospital with COVID at the same time this month. She's home and on oxygen. Her mom's still in the hospital. And unfortunately, I just saw yesterday that her dad did pass away from COVID. So I just wanted to make the point that these are real people and not just numbers. We've been going through a lot of numbers, but these are real people. So we have all of this misinformation going around social media. We have filter bubbles giving us what we want to see. We have political figures that people trust to be truthful, sharing much of this disinformation, and then people re-sharing it in our social circles. So no wonder there's a noticeable split in perceptions across political parties. So here are some graphs from Pew Research Center, and they really demonstrate the diverging opinions between the political parties over time during the year 2020. The first one is how well the media was covering COVID, and then the middle one is perceptions of whether health officials like those at the CDC were exaggerating the risks of COVID. So you can see in that first graph, Democrats or Democrat-leaning opinions were staying pretty level, but Republicans' opinions of saying the media was covering the coronavirus outbreak well dropped from March to September 2020. And then the middle one, you can see that Republicans' perceptions of public health officials exaggerating the risks of COVID went way up just between March and April 2020. So 26% to 38%, and while Democrats' opinions of that actually decreased. And then you can see in this third graph that these beliefs led to a disparity in self-reported mitigation behaviors like social distancing or mask wearing or going to work. So you can see that this also resulted in differences in behaviors. So this is a poll from February and March of this year, 2021, that shows that the majority of Americans, about 70%, say that they trust their nurses, healthcare workers they know, and doctors a great deal, while only about 52% say they trust the CDC a great deal. And while only about 5 to 7% of people said that they do not trust healthcare professionals, 20% said that they do not trust the CDC. So we have about 1 in every 5 Americans saying that they don't trust the CDC, not very much or not at all. And then local and state health departments were trusted even less. Only 41 to 44% of people said that they trusted their state and local health departments a great deal. And even in Utah, we saw protests at the personal home of our state epidemiologist, who is not an elected official, but a civil servant. So all of this dialogue surrounding the disinformation and having to repeatedly focus on correcting disinformation distracts us from the real ethical dilemmas surrounding the pandemic. If we can't agree on a baseline perception of reality, we're never going to agree on the best way to address a situation. So a few examples of real ethical dilemmas, that we could be talking about instead of fighting disinformation constantly, are preventing increased domestic violence and addressing mental health issues during shutdowns that are intended to slow the spread of disease and intended to not overwhelm the medical system. Another is considering low-income and single-parent families during school closures. Are those kids going to end up staying with their grandparents who might be more high risk? Another is considering kids themselves who are high risk or kids who live with high-risk family members going to school when there's no mask requirement in school. Are they being excluded? Another is accommodating children who have sensory disorders or people who rely on lip reading when it comes to mask requirements, because some people are more adversely affected when it comes to mask requirements. And then a few more recent ethical questions include whether or not it's ethical for lawmakers to limit health department and school districts' abilities to institute mask mandates. We've seen lawsuits and recent court outcomes about this in several states. And then another recent debate is under what circumstances vaccine mandates are and are not ethical. So I talked a lot about numbers, but I wanted to finish off with a story about why we should care about all of this. We should care because social media disinformation affects real people. This photo shows our family friends, Mindy and Russ. They live on the same street as my parents in Saratoga Springs. Mindy had a lot of concerns about the vaccine after she scrolled through social media and friends sent her YouTube videos with false information about the vaccine, including the claim that the vaccine was a bioweapon, and she decided that her family would not be vaccinated. This included her healthy and active 42-year-old husband, Russ. And then one day their son came home from a church camp with COVID, and both Mindy and Russ contracted COVID. Not long after, Russ was rushed to the hospital. He spent more than 2 months intubated in the hospital, had surgeries, had a tracheotomy. There were multiple times when the medical professionals thought that he wouldn't make it. And even while Russ was in the hospital fighting for his life, friends were sending Mindy ivermectin and telling her even in the hospital lobby that the COVID vaccine is bad. So throughout her time on COVID row, Mindy met a lot of other families with loved ones, many of whom had been perfectly healthy with no pre-existing conditions who were dying from COVID-19. And she also had time to speak with medical professionals about the vaccine and her concerns about it. So Mindy then posted on Facebook while Russ was still in the hospital, and I quote, "We did not get the vaccine. I read all kinds of things about the vaccine and it scared me. So I made the decision and prayed about it and got the impression that we would be okay. If I had the information I have today, we would have gotten vaccinated." And in her post, she also urged individuals who are nervous about getting the vaccine to write down all of their concerns and talk about it with a trusted doctor. A few weeks ago, Russ was able to come home. It was really nice because the whole community came out and kind of rallied around him to welcome him home. There were balloons everywhere. Russ's dad and wife helped him out of the vehicle. They immediately put him in his wheelchair and hooked him up to his oxygen. His 4 kids were able to give him a hug. He was in the hospital a long time, and it's still going to be a long road to recovery, but he was one of the lucky ones who started off intubated and then pulled through. So Mindy now, knowing how disinformation personally impacted her family, is publicly speaking out about the misinformation online, which I think is extremely brave of her. So lastly, I just want to give a few quotes from Mindy. She said, "I do believe it's really hard to get an answer when the noise around you is so loud. I will always regret that I listened to the misinformation being put out there. They're creating fear. Educate yourself with facts and then make the decision, but you cannot make an educated decision on fear and lies." And then during Russ's homecoming, she said, "You have your opinions, we have our experience." Thank you all for your time. The last speaker in this session will be Dr. Heather TSA.
Thank you, Dr. Hall. Hello, my name is Heather TSA, and I will be discussing the topic of personal freedom versus community good, vulnerable populations, ethical challenges, access and cost of care related to the pandemic. No. Sorry. Okay, I apologize. It's going back through Sarah's presentation, which is amazing. But let's see if we can go to mine. Here we go. Apologize for that delay. The pandemic has invoked strong reactions from the American public, painting public health measures like masking and vaccination as violations of our personal liberty. Public health policies and infrastructure are the backbone of the necessary societal conditions that ensure healthy lives, and thus freedom to thrive for all. As Dr. Ensign said, examples of this include safety driving laws and seatbelts, which we're all familiar with, and which became here with very strong arguments as well in the 70s and 80s. After then Secretary of Transportation, Elizabeth Dole, issued a rule in 1985 that required automakers to install driver's side airbags in all new cars, unless, and here's our caveat, 2/3 of the states passed mandatory seatbelt laws by April 1st, 1989. Lobbying from General Motors, which you can probably imagine became very intense and threats of removing manufacturing plants, which were thereby threats to the economy, had lawmakers very interested in these public safety measures. The community then followed with their compliance. While public health measures may seem to be encroaching on personal liberties, this is how we function under our social contract to our community and society. Strictly with a biostatistical perspective, if we look at the hazards ratio or implications from the vaccine versus the high rates of mortality and long-term morbidity or side effects from the vaccine, it is abundantly clear that vaccines offer the safest and most effective protection against complications and death. That kind of morbidity and mortality in our community, if we can get enough people, which is 70 to 80% of our population, so that we can have herd immunity, or the majority of vaccinated people indirectly protecting the unvaccinated with their own immunity. Masks work to reduce spread. They may not be 100% effective, but they're better than not masking, which would be 0% effective. An emergency room doctor at the University of Utah recently commented, "Healthcare workers wear masks to protect ourselves from getting COVID-19 each time we go to work, taking care of you and your loved ones. We do this so that the healthcare workforce doesn't go down. If masks didn't work, we wouldn't use them." Masks block as much as 50 to 70% of exhale droplets. If the infected person wears a mask and the uninfected person wears a mask, this substantially reduces the risk that COVID is transmitted. Elementary schools are just about the only place in society we require people to go who don't yet have the chance to be vaccinated against COVID-19. And COVID-19 is such a spreadable pathogen that a multifaceted approach is required to keep our communities working and people safe. We know from experience last year, just here in the state of Utah, mask mandates in schools work. They limit breakouts, allowing children to stay in school, keep parents working, and our economy functioning. Most importantly, we will also avoid creating chains of transmission through schools, chains of transmission that will inevitably lead to deaths among the most vulnerable citizens of our community. Public health policies and infrastructure are the backbone of the necessary societal conditions that ensure healthy lives and thus freedom to thrive for all. Our freedom is a result of structured public health actions and policies, which ensure that we are healthy enough to work, to play, and to learn. Our freedom, if the preferences of certain persons are given priority over the lives of others, especially when facing a new infectious disease whose transmission can be slowed by small and simple means. This is especially true for vulnerable populations, such as children and immunosuppressed patients. Currently, patients under the age of 12 are not authorized to receive vaccinations under the FDA emergency use declaration for Pfizer, Moderna, or J&J. While Pfizer has now received full FDA approval, this still only includes people over the age of 18. While we anticipate that result from clinical trials will be presented very soon to the FDA, this still leaves a time period where our children are at the mercy of adult fatigue from public health measures, such as mask wearing and political pushback. Immunocompromised patients, such as transplant patients, are another particular risk. In my career, I worked with transplant patients. These patients are given medications to suppress the natural immune system reaction in order to have a foreign body or transplanted organ in their body. Thus, we are purposely suppressing their immune system so that they can survive and not reject their new organ. This includes thousands of patients worldwide. This leaves transplant patients at great risk during a pandemic. They're not able to get the care that they need when needed. As an example, 3 weeks ago, one of our liver transplant patients came in for critical symptoms. Providers tried to directly admit him to the ICU for his condition, but due to a lack of rooms, he waited in an ER observation unit for 2 days, where he ultimately internally bled until he went into cardiac arrest and succumbed to his condition. Our vulnerable populations are left unprotected and unable to get care in an overburdened system. It is estimated that the pandemic has caused the death of over 17,000 frontline healthcare workers globally. Furthermore, many providers have left due to burnout from extreme duress and even PTSD symptoms. This cost on our healthcare providers has been staggering and will have long-lasting effects on the healthcare system and future providers as well. Some providers who may be deterred from the profession altogether because of this pandemic and society's distrust of the medical and scientific community. A recent study of roughly 5,000 patients done here in Utah in 2020 showed that patients with chronic opioid use and other chronic diseases were at greater risk of severe complications from COVID-19 and represent another vulnerable and often neglected population. COVID-19 patients with opioid use disorder averaged longer hospital stays than those without opioid use disorder, 9.53 days versus 0.7 days. COVID-19 and opioid use disorder patients were also more frequently hospitalized, admitted to the ICU, and received mechanical ventilation. When we adjusted for age, sex, race, and the presence of underlying medical conditions, including diabetes, asthma, hypertension, cardiovascular disease, and chronic pneumonia, COVID-19 patients with opioid use disorder were 4.3 times more likely to be admitted to the hospital as an inpatient. These are just a few of the many vulnerable populations in the face of hundreds of other chronic diseases and conditions with similar outcomes. Health, as well as Intermountain Medical Center and Primary Children's Hospital, are the only level 1 trauma centers in Utah, but they also serve a 5-state radius, including Montana, Idaho, Wyoming, Utah, and parts of Nevada for their high level of care and specialties. They have also been the main referral centers for critical patients needing extracorporeal membrane oxygenation, or ECMO, where the blood is oxygenated outside the body for very critical patients, and extended ICU stays with mechanical ventilator care. Utah's ICUs are 95.9% full. This does not mean that they have the specialized staff necessary to care for these patients. However, the COVID-19 pandemic has created real ethical dilemmas of who should receive care in overburdened medical centers and who should be transferred for higher care. Hospitals have been reporting near the brink in capacity for ICUs and hospital beds since the recent surge in COVID-19 cases in August of this year. From the Delta variant, hospitals are under obligation to care for the patients already within their own doors and cannot accept transfers from neighboring hospitals and states if their own are filled. Primary Children's Hospital, as an example, recently lost roughly 35% of its hospital beds, including beds in their intensive care unit, from flooding caused by heavy rains that went through 3 floor levels. Primary Children's Hospital is unique in being the only pediatric hospital to serve the Intermountain West. This latest flooding challenge, on top of a surge in pediatric hospitalizations from COVID-19, has greatly affected its ability to receive referrals and transfers from other hospitals. Yet we still continue to send children to school unprotected. This has also caused our children to not be able to get the care they need, as all non-emergent surgeries at the hospital, along with other procedures, are being postponed or canceled altogether. This includes diagnostic procedures as well as treatments, leading to prolongation of pain and sickness for many children throughout the Intermountain West. Another recent example is our bordering state of Idaho. Idaho has one of the lowest vaccination rates in the US, second only to Wyoming, with only 40.9% of the population vaccinated. A recent surge in cases has left the system inundated with extremely critical patients, to the point that they've had to start rationing care. The Idaho Department of Health and Welfare made the announcement after St. Luke's Health System, Idaho's largest hospital network, asked state health leaders to allow for crisis standards of care, because the increase in COVID-19 patients has exhausted the state's medical resources. This means that they judge who they can treat by standards of who is most likely to survive, as well as who has the most potential years of life left. While this health system has been at capacity and trying to transfer patients who need higher level of care to neighboring partners, other neighboring states that have had more strict public health measures, including masking and higher vaccination rates, have been reticent to accept transfers, thereby reserving care for the patients within their states. Doctors at the major hospitals in Coeur d'Alene, Idaho, spend a large part of their day, some estimates have even been quoted at 8 hours, trying to find beds for their patients. They have also had to bring in refrigeration trucks to accommodate the increased rate of mortality and morgues that are at overcapacity. Montana and Alaska are also implementing crisis standards and rationing care. This is an extremely draining and demoralizing burden placed on our healthcare providers to be the judges of who receives care and who doesn't, which goes against their Hippocratic oath. So in a disjointed US health system, we are left with the ethical question of who is responsible for care of patients, especially in rural areas that depend on referral care and transfers. The costs of care during the COVID-19 pandemic have been astronomical, including lengthy hospital and ICU stays, extended periods of mechanical ventilation use, and even extracorporeal membrane oxygenation, or again, ECMO. The mean estimated cost for the ECMO procedure per patient stay was estimated at $73,000 US. Patients in the ICU who require mechanical ventilation as part of their care are estimated at having 5 times the cost of a standard daily cost of the ICU, adding an additional $1,522 per day. These costs have been devastating families, patients, hospital systems, and insurance companies, which in turn passes the costs along to all their members. So in light of vaccination as an effective prevention strategy with 86% efficacy against severe disease, should patients who choose to be unvaccinated be held more responsible for care if they do require hospitalization and higher care? Insurance companies are currently considering this dilemma and considering requiring monthly surcharges for unvaccinated patients, as well as being required to cover more of the burden of their hospital care. Delta Airlines recently announced that starting November 1st, it would require a monthly surcharge of $200 for health plan users that are unvaccinated. United Airlines and others have instead just mandated vaccinations for all of their employees. The legality of raising premiums and having unvaccinated patients cover more of the burden of the care are topics currently being debated. However, this leaves employers and insurance companies with the ethical decisions of who should be on the line for these increased costs. These are difficult times, and we know that there are lots of unique situations and differences of opinion. We need to keep this conversation open and based on similar facts. We know as a society we are dealing with disinformation, distrust, public health measures, fatigue, as well as an increased rate of mental health conditions, including PTSD, because of this pandemic. But we know that as we work together and seek for the common good, we can get through the many facets and complex concerns of this pandemic. We thank you for your time, and we will now take any questions.
Thank you for your presentations. Those are very interesting discussions that you have opened for us. We do have a couple of questions. The first one is, we often hear people saying, do your own research. Could you speak to what doing one's research could constitute? Is the general public able to conduct this kind of activity?
I can start and see if anyone has anything to add. Oh, sorry. Go ahead. Go ahead, Dr. Ensign.
I was just going to jump in because it was quiet, but I'll go first then. So I was just going to say that, yes, the general public does have access to this kind of information. What I would recommend staying away from is a Google search that looks something like, why should I not wear a mask, or something like that, because it will lead you directly to some opinions that are out there. There is something called the evidence-based triangle that we learn when we are learning to do research and to publish research. And at the very bottom of that triangle is actually expert opinion. So that may have some good evidence-based data in it, but it gets better from there as you go up. You start to look at random controlled trials that have a large number of participants in it. And the more participants you have, if it's a double-blind study, there are ways that we judge articles and information to know if it's more evidence-based and it's more reliable. So we sort of learn how to apply that to our research to know. But from the general public's perspective, I would say, as you are looking, I would go to some sites like the CDC or the Department of Health. These are generally considered to be reliable, and they'll have some guidance for you with some regional information. And then the medical journals that dig a little bit deeper that I rely on quite a bit would be like the Journal of American Medical Association, the New England Journal of Medicine. The reason these ones are considered very valid and reliable is that they're peer-reviewed. They publish original research, which is important. So they're not involved in that circular reporting that I talked about during my segment. It's more original research. So you know exactly where it's coming from, and it will describe the methods that were used. So those are a couple of medical journals that I would rely on. And they do, I think it costs money to subscribe to those journals, but during COVID, they are offering free information. So that would be a great thing to look for, and that the general public can look to.
Dr. Jensen, go ahead.
Can I just add here too that PubMed is a database that's curated by the government. So that means all of our tax dollars are supporting this. And there is free information that's available there for every single citizen in the United States that has an internet connection. So I would point you towards that as well. It has very easy search features, and you would have access to the same information that researchers would have as they're getting ready to do their own individual research.
And I would add peer-reviewed studies published in scientific journals are kind of higher caliber. You want to look for those. Somebody mentioned case control studies before, or like large real world data studies. I would also add coronavirus.utah.gov if you want to look at more like something easy to see, where you can see case counts and deaths and things like that in the state of Utah. Johns Hopkins website also updates a lot of information by country and so forth with COVID statistics.
I would just add to write down your questions and go to a trusted medical professional. And if you don't get all the great resources here from our presentation that Dr. Jensen, Dr. Enzen, and Dr. Hall have just mentioned, they can help lead you in some of these ways. Make sure, because yes, there are differences of opinion amongst healthcare providers, professionals, but someone that is treating or diagnosing COVID-19 patients can give you great information. Usually these are a primary care provider.
So the other question in the chat was asking where else can I get information besides the CDC? So I think all of you answered those questions, and that was great information to share. Do any of you have anything else that you would like to add?
So just one thought on that too. I know we've mentioned this in the presentation, but the World Health Organization does give great information. It is a more of a global perspective, but you can narrow it down and look to the different areas that you are in that are more applicable to you as well. But they're a great resource.
I just want to add, I think that we all want the same thing. I think we all want health and happiness and a robust economy. And, you know, I think we're all looking for the same things, but we need to all get on the same page about what's happening, because there's so much disinformation just being thrown every which way. We all need to sift through that, figure out what's really going on, and then we can better work together to solve these problems. You know, arguing isn't really getting us anywhere. So we've got to get on the same page, and we got to work together to solve all of these problems that are going on.
I think we're good to end the topic and the conversation. I appreciate the information you have shared with me, as well as the community that you were addressing. And I think we are okay to end the session and allow people to move on to their next opportunity.